Now we move from virtues to principles. The principles are the rules and standards that guide your actions. And these are the four big principles that are the foundation of all nursing ethics. Now, plus three additional ones that you must know. So, but first, let's talk about the origin of these principles. This framework is called Principalism, and it was created in 1979 by two philosophers, Beauchamp and Childress. No, Tom Beauchamp and James Childress. They published a book called Principles of Biomedical Ethics, which became the standard for all healthcare ethics worldwide. So they chose these four principles because they are universal. When we say universal, it's applicable to all. No, accepted by all cultures, religions, and professions. Okay? The first principle is beneficence. Ito, we have already discussed this in the previous session, right? So, now, but we will be discussing it more in detail in this session. So, beneficence, as we have previously mentioned, it basically means to do good. We act in the best interest of patient. We promote their well-being and we provide quality care. No, the origin of beneficence is that it is from the Hippocratic Oath, no, in 400 BC. In that phrase that says, "I will apply measures for the benefit of the sick according to my ability and judgment." So that statement in the Hippocratic Oath talks about beneficence. So your number one duty is to do good. Everything you do must be for the benefit of the patient. You seek to improve their health, their level of comfort, their safety, and overall their life. For example, you turn a bedridden patient every 2 hours, not just because it is a task, but to prevent bed sores and keep them comfortable. That is beneficence. Second is non-maleficence, which basically means doing no harm. We avoid causing injury or suffering to patients and minimize potential risks. It is also from the Hippocratic Oath. No, um, it is when Hippocrates said, "Primum non nocere," or first, do no harm. This is the oldest and most famous rule in medicine. This means you must never hurt, damage, or cause suffering. You must also reduce the risks. You have to prevent mistakes, prevent infection, prevent pain. For example, you are double checking medicine dosage to avoid overdose or wrong drug. That is non maleficence. Then the third one is justice or fairness. It is when we treat patients equitably, distribute resources fairly, and uphold procedural justice. It is from Aristotle's concept of distributive justice. No, giving each person what is fair and equal. No, later developed by John Rawls, no, in 1971 in his theory of justice as fairness. Everyone gets what they deserve. So you do not favor the rich, the powerful, or your relatives. You treat all patients equally. You use hospital resources fairly. No, the time, the medicine, the beds, the equipment. For example, you give the same quality of care to a very poor patient as to a wealthy one, and that is the practice of justice. Okay, and next one is autonomy, no, which is pertaining to self-determination. It is when we respect patients' right to make informed decisions about their own care. No, it is from the philosophy of Immanuel Kant and the human rights movement of the 20th century. It became central after the Nuremberg Code in 1947. no, yung autonomy. Created, this Nuremberg Code was created after World War II, no, to protect the people from abuse. So it says the voluntary consent of the human subject is absolutely essential. Okay? This means the patient is the boss of their own body. You cannot force them to accept or refuse treatment. You must respect their choices even if you disagree. For example, a patient says, I do not want surgery. Even if you think it is best for him, you still respect their decision. And that is practicing autonomy or honoring autonomy of the patient. Okay? Now let's talk about the additional principles. These are also from Uchab and Childress book, no, and from the International Council for Nurses Code of Ethics. First one is confidentiality, which protects, basically means protecting patient information. It is also from the Hippocratic Oath. On that phrase, what I may see or hear from the course of treatment, I will not divulge, considering that all such should be kept secret. So, and that is that statement is all about confidentiality, no, from the Hippocratic Oath. So everything they tell you, no, the patient tell you, everything you see, everything you record, must stay as a secret. You do not share it with anyone, not even your family, unless the patient, or not even the family of the patient, but unless the patient will allow it. Okay? So, for example, you do not talk about the patient's illness in the canteen or in the social media or in the elevator. Okay? Next one is veracity, which is truthfulness in communication. It is from the duty of honesty and respect for human dignity, formalized in nursing ethics in the 1960s to 1970s. So, nurses tell the truth. No. Clear, honest, and complete. You do not lie. You do not hide facts. For example, you explain the side effects of a medicine. You do not say it has no problem. If it has a problem. Okay? If there are side effects, then you tell you know you divulge the side effects, right? Then the next one is fidelity. It is when we keep promises and commitment. I think we have already discussed this a while ago. But yun. Fidelity is basically keeping promises and commitments. It's from the concept of loyalty and trust, no, central to the nurse-patient relationship since Florence Nightingale. Okay, so uh, we actually, as I've said, we discussed it earlier, but as a principle, it means you are bound by your word. You are reliable, no, and trustworthy. Okay? So these seven principles are your moral compass. Every decision you make must be checked against these. Okay? Asking yourselves, am I doing good? Am I avoiding harm? Am I being fair? Am I respecting the choice of my patient? So, beneficence again is always acting for the best interest of the patient, no? Or it's acting for the good of others. It's an act of mercy, kindness, and charity, humanity, and altruism. Other examples, nursing examples of practicing beneficence would be when you resuscitate a drowning victim, no? When you lift side rails to prevent falls, when you feed the patient, no, particularly like the example, the elderly patient. Another is when you provide pain medication, no, or even in simple hand washing, when you practice proper hand washing, no, that is actually doing, no, that is practicing beneficence. You're doing proper hand washing for the best interest, no, of the patient. And then next is, for example, when you are providing psychosocial support. Okay, so uh, Basically, beneficence, no, uh, help and heal, no, in nursing. But here is the hard part, no, when there are ethical conflicts, and there are other ethical principles, no, that can clash with beneficence. Of course, when two good principles clash, no, when two good principles contradict each other, you cannot do both. You must choose. And these conflicts, no, in this slide, no, are the most common, identified by Buchamp and Childress, and are also taught, no, in every nursing school. Um, First is the clash between autonomy versus beneficence. Like for the patient, like for example, when the patient refuses life-saving treatment. So for autonomy, patient says no to the life to the treatment. They have the right. For beneficence, you want to save their life. So you want to do good, and that is beneficence. Now the conflict is, I want to save you, but you won't let me. So, okay. Another example is when a Jehovah's Witness, no, patient that refuse blood transfusion, even if they will die. So in this case, autonomy wins. You respect their choice. Okay. Non-maleficence can also clash with beneficence. Uh, like for example, when there are necessary painful treatments. Beneficence, the treatment will cure or save the patient. For non-maleficence, the treatment will hurt. The treatment will cause pain or risk. Now, the conflict is, I want to help you, but I must hurt you a little. No? For example, surgery, chemotherapy, wound cleaning. No? But in ethics, of course, it is allowed, no, the risk and the pain and the hurt is allowed if the good is bigger than the harm and if it is necessary. Okay? Yeah. Um, Later we'll be discussing about the principle of double effect, to discuss more about this rule. Justice also can clash with beneficence, like in the case of resource allocation dilemmas. So, for example, in beneficence, I want to give everything to this patient. But justice will say we have limited resources, we must share fairly. Now, the conflict is when I want to help you, but we don't have enough for everyone. So, for example, there is only one ICU bed left, but two patients needed. You have to decide fairly. Okay? Then next is confidentiality that can also clash with beneficence. So, uh, like in the case of protecting patient or others from harm. No? So, confidentiality tells you that you must keep the secret. You must keep your secret. But beneficence and having that duty to warn is when if your secret will hurt you or someone else, I must speak. Okay. So the conflict is I promise not to tell, but I must save a life. Okay. For example, patient tells you I will kill myself or I have HIV and I will not tell my partner. So the rule is you must break that secrecy to prevent harm. No. So yon. Now, whenever these conflicts occur, we must know how to decide ethically. And there are frameworks, no, that we can use to decide ethically. We will be discussing more of this framework in particular case scenarios in the succeeding slides. Now, here is a classic case you will definitely see one day. Now, listen closely because it explains the hardest rule you will use. The situation is a patient comes in with a very bad infection in their foot. The tissue is dead and rotting. The doctor says we have to remove the foot, we have to amputate it. If we don't, the infection will go to the blood and they will die. So, and the dilemma is for beneficence, we want to save the life of that patient, which is actually good. For non-maleficence, cutting off a foot is definitely harm. It hurts and it also will change the life of that patient. You might think, wait, what are we supposed to do? Isn't it that we're supposed to do no harm? Then why are we amputating? Why are we cutting? Now, how do you navigate this? You use the principle of double effect. No, this is your number one tool for hard decisions. It says that an action that has a good effect and a bad effect is allowed if you follow certain rules. And there are four rules no, in the principle of double effect. Number one, the act itself must be good no, or neutral. In this case, saving life definitely is good. The second rule is that you only want the good result. You don't want to cut the foot, you just want to save the life. And the third rule is the good result doesn't happen because of the bad part. You save life by removing infection, not by cutting it. Okay, so and the fourth is the good is way bigger than the bad. So saving life definitely is way a lot bigger than losing a foot. So the proposed decision definitely is to amputate. Now, as a nurse, you have to explain this clearly to the family. You have to get their consent. You also have to administer pain medication to the patient and also prepare for the patients for rehabilitation. So, what is the lesson here? Sometimes doing good means doing something difficult or painful, but only if the benefit is much greater no, than the harm. Okay? Another difficult thing that you will ever face in our profession is that when there is not enough resources for everyone. So let's go through these carefully so you know exactly what to do. Well, in this situation, uh, no, imagine a big emergency or pandemic. No, the hospital is full. There are only 3 ICU beds, but there are 5 patients who are very sick and need intensive care to survive. As you gather data, you have gathered that uh, information about the patient and their chance of survival. So the first one patient is 30 years old, no, suffered from accident. And according to the data, he has 85% chance. Another one is a 75-year-old patient who has lung disease, and according to the data, he has 60% chance. The third patient is a 45-year-old patient who had a cardiac arrest, a heart attack. According to the data, he has 40% chance. The fourth patient is a 25-year-old patient with infection. According to the data, he has 75% chance. And the fifth patient is a 55-year-old patient no, who suffered from stroke. And according to the data, he has 30% chance. Now, again, you only have 3 ICU beds, but you have 5 patients who needs ICU treatment. So the dilemma now is who gets the bed? Who do we leave out? Of course, it would feel terrible, no? Deciding on this. But of course, you must choose fairly. Now, how do you navigate this kind of situation? Then we use the principle of justice and utilitarianism. Um, you have to make fair rules first. We give beds to the patients with the highest chance of survival. no? And then you apply these rules equally. So if you will take a look at the five patients, uh, the patient with the high survival rate, no, is that 30-year-old patient who had an accident. So since highest ang survival rate niya, then of course, yes, he will be given the bed. Now, how about the 75-year-old patient who has a lung disease? According to data, he has 60% chance. So if you take a look at the survival rates, he is actually the third. So yes, he will be given the bed. And the other one is the patient who has a 75% chance, the 25-year-old with infection. So these first three patients will be given with the highest survival rate will be given the ICU beds. No, the 45-year-old with the heart attack and the 55-year-old with the stroke has the lowest chance of survival rate. So unfortunately, no, they will not be given the ICU bed. So, but even though they will not get the ICU bed, they will still be monitored closely and given other care. Okay. Now, fairness. No, the lesson here is that fairness means following clear rules, not picking favorites. We save the most lives possible. It is of course hard, no, a hard decision, but it is ethical. Okay. Now, let's dive in this time to the next ethical principle, the non-maleficence or do no harm. As we have said previously, that this is the oldest rule in medicine. It means you must never hurt the patient. No, first, do no harm. Uh, do not hurt the patient, whether it's physical, mental, emotional, or social. And harm is not just hitting them or giving wrong medicine. Harm is also speaking harshly or making the patients feel stupid. No, it also means leaving the patient alone when they are scared. Uh, it also means using broken equipment that might hurt the patient or gossiping about the patient. No, these are other examples of causing harm to the patient. No? If we take a look at the different theories, again, going back to the different theories in deontology, harm is wrong because it breaks the rule. In teleology, harm is wrong because the result is bad. And in virtue ethics, harm is wrong because it shows bad character. Now, your job as a nurse is to always protect the patient from harm, whether big or small. All right? To elaborate more, no, on the ethical perspectives on harm, we have mentioned a while ago of what is harm according to the different theories. No, um, so for deontology, harm is breaking the rule. So don't hurt is a rule. So hurting is definitely wrong. For teleology, we said a while ago that harm is a bad result. So if the outcome is pain or injury, then the action is bad. For virtue ethics, we said a while ago that harm comes from bad character. So if you are kind, you don't hurt people, and hurting means you lack kindness. So for us nurses, no, we define harm simply anything that hurts the patient. No, whether it's physical, mental, emotional, or social. Okay, so yun. And our goal, no, is to prevent all of these harm for our patient. Now, what happens again when non-maleficents are in conflict with other ethical principles? Um, let's take a look at the most common common conflicts involving non-maleficence. Uh, First is the conflict between do no harm and do good, between beneficence and non-maleficence. Now, for example, surgery. No, it hurts, which is harm, but it saves lives, which is good. So the solution is to follow the principle of double effect. No? Um Another sample conflict is between do no harm versus patient decide. So non-maleficence in conflict with autonomy. For example, patient says, "Give me enough medicine to stop my breathing." So autonomy, patient wants it. For non-maleficence, it will kill them. So that is harm. So the solution is to refuse. You cannot help the patient to hurt themselves because our duty is to give comfort, no, not to to help in dying, okay, or help patients kill themselves. No, that is not our job. Okay, another example of conflict is the conflict between non-maleficence and justice. So a conflict between do no harm versus be fair. For example, again, the case scenario that we had a while ago, no limited bed. Someone will suffer if they don't get it. So the solution is to choose the option that causes the least harm overall. So we save the most lives possible. Okay. As a rule, no, when in doubt, we need to minimize harm. Whenever are in doubt about these ethical conflicts with non-maleficence, the rule is to minimize harm. Okay? Now let's discuss this case scenario, no? For harmful treatment demand. This is actually very sensitive, a very important case that you will see in end of life care. So listen carefully. The patient, no, for the scenario is the patient has terminal cancer. They are dying and they are suffering from terrible pain. So they tell you, no, uh, they they told you, no, "Nurse, please give me a big dose of that medicine, enough to make me sleep, no, and never wake up, because I can't take this pain anymore." Sabi ng patient. No? Your dilemma as a nurse is that, yes, autonomy, they asked for it. So should we respect their choice? For beneficence, we want to stop their pain. Of course, we want to help the patient. We need to, no, we want to help the patient feel comfort. So we want to relieve their pain. For non-maleficence, the big dose will definite the that dose of medicine, no, that they are asking or requesting will stop their breathing and kill them. And definitely that is uh, killing, no, that is harm. Now, how do you navigate this situation? Remember again the rules. We must relieve their pain. We must never intentionally kill. No? So autonomy does not mean you can help me die. Okay. Also, the second step is to use the principle of double effect. We give the maximum safe dose that relieves pain but does not kill. Okay. The intention is for pain relief only. Yes, there might be side effects. No, it will make them a little sleepier. No, but that is okay. But to cause death, definitely that is not the intention. Now, what are you going to say and do? So you hold their hand and say, "Yes, I hear you, and I know the pain is terrible. I promise I will give you enough medicine to make you comfortable and stop the pain. But I cannot give you something that will end your life. That is not my job, and it is also not right. But I will stay with you. I will help you, and we will make sure you do not suffer." Also, that is one example of what you're going to do to this kind of patient who is requesting a harmful treatment. So the proposed final decision is, of course, to maximum safe dose for comfort and refuse the overdose. Now, what is the lesson from this case scenario? That our duty is to relieve suffering, no, not to cause death. We balance comfort and safety. And autonomy has limits. It does not include the right to be killed. Okay? Do you understand that? Moving on to our next ethical principle, justice. You, of course, you probably heard this word before. It basically means fairness, treating everyone equally and giving people what they deserve, what is their due. Now, in healthcare, justice has two main parts that you need to know. First is distributive justice. This is the big one that we use every day. It's about sharing fairly. Since we don't have unlimited money, beds, medicine, or staff time, we have to decide who gets what. Okay? We decide based on need. Who needs it the most? We also decide based on benefits. Who will get better? And we also decide based on equality. Everyone gets a fair chance. So we can't give everything to one person just because they are rich or famous. Everyone gets a fair share based on their need. For example, again, if there are only two ICU beds left and four patients need them, we give them to the ones who are sickest or have the highest chance of recovery, not to the one who shouts loudest or knows the doctor. Another example, if there is only one dose of medicine left, we give it to the patient who is sickest and not the one who pays more. Okay? The second is procedural justice. This means that the rules and the process are the same for everyone. No special treatment, no shortcuts. Everyone waits the same way. Everyone follows the same steps to get care. For example, in the emergency room, we follow the triage system. The most serious cases get seen first, definitely, no matter who you are. That's a fair process. There are actually two other types of justice, uh, but we do not use them um, in nursing most of the time. So we rarely use them. Third is retributive justice. This is actually about fair punishment. If someone does something wrong, like a nurse hurting a patient or stealing medicine, they get fair consequences. Not too hard, not too soft. The fourth is compensatory justice. This is fair payment for harm. Now, if the hospital makes a mistake and hurts a patient, they pay fairly to fix the damage. Okay? So, yun. Remember, in nursing, we use distributive and procedural. Justice the most. Uh, okay? So, these two types of justice, we use them the most. We always ask, is this fair? Is it the same rule for everyone? Okay, did you get that? Now let's take a look at a case that is in conflict with justice. Now, and in this case scenario, it's a conflict between justice and fidelity. Um, it's a real situation that you will definitely face one day, as a nurse. So let me walk you through, step by step. The situation is that imagine yesterday you were assigned to take care of patient A, a sweet elderly person. You talked to them and said, "Don't worry, ma'am. I will be your nurse again tomorrow. I promise I will take good care of you." Patient A smiled at you and trusted you completely. Uh, okay. Then the next day, you came back to the patient. You were assigned again to that patient, and that's fidelity, keeping your word. Okay. But and you did it again. You promised again that you will come back the next day again. And the next day arrives. Suddenly, patient B is rushed in. No, another patient comes in. That is patient B. They are in. That patient is in a critical condition, very sick, and you're the only nurse available with the skills to help them. If you stay with patient A, patient B might get worse or even die. So the dilemma is you are torn. On one hand, you promise, that's fidelity. On the other hand, patient B needs you more urgently, and everyone deserves fair care. That is justice. Now, what are you going to do? How are you going to navigate this kind of situation? First, Of course, promises are important, but patient safety is always number one. In this case, patient A is stable and safe, but patient B is in danger. Okay? Second, fairness means helping those who need it most. And third, you can still take care of patient A, just not you personally. You can assign another good nurse, no, to them. Um, okay. So what are you in the actual situation? What are you going to actually do and say? You have to go to to patient A, no, hold their hand and say, "Ma'am, I am sorry. I promised I would stay with you, but there is a patient who is very sick and needs my help urgently. So I have assigned another nurse, no, to take care of you. She is also very kind and very good. I will come back to see you as soon as I can." Okay? So that is how you tell the patient, no, in this kind of situation. And of course, the proposed final decision is you have to go help patient B. Now, the lesson here is that justice and safety comes first. But you must always explain and apologize. You don't just leave. You communicate and make sure everyone is cared for. Okay, is that clear? Here is another case, no, that shows conflict between conflict against justice. This is a case about justice versus confidentiality. And again, another difficult case. So let's go through this carefully because it involves law and ethics together. Now, the situation is a patient comes to you and says, "Nurse, I have HIV. Please don't tell anyone, especially not my wife. She doesn't know and I don't want her to leave me." The dilemma here is that, of course, for confidentiality, you promise to keep his secrets because this is a private health information. Uh, on the other hand, justice also, uh, of course, reminds you not to that there is that you have a duty to protect. And in this case, his wife is innocent. His wife is sleeping with him, as per which is revealed during the interview. So the wife is high risk also of getting the HIV. And the wife also has the right to know so she can protect herself. Now, how do you navigate this kind of situation? First, of course, is you have to know the rules again. Confidentiality is not absolute. No, the rule says keep secrets except when keeping the secret will hurt someone else. Also, in the Philippine law, you must report communicable disease. No, you have to report communicable diseases like HIV to the Department of Health. It is not optional. It is required by law. Okay? So step two is you try the best way first. You talk to the patient gently. "Sir, I understand you are scared and I want to help you. But your wife is also in danger. And she deserves to know so she can stay healthy. So let's tell her together gently, and I will be with you both, no, as you tell your wife." Okay? So that is how you're going to talk to that is just one example on how you're going to talk to this kind of patient. Now, in step three, if he still refuses, you do not tell the wife directly to protect privacy. But you must report to public health because that is required by law. They have a system to inform partners confidentially and safely. Okay? So the final decision, of course, is to report to health authorities. The lesson here is that safety and justice are more important than keeping a secret that will kill someone. Okay? Did you get that? Now, let's talk about one of the most powerful principles in healthcare ethics, no? The principle of autonomy. Simply put, autonomy means every adult patient who is mentally capable, no, has the absolute right to decide what happens to their own body. So it is their life, their health, and their choice. Think of it like this: you wouldn't want someone else choosing what you eat, right? Where you go or what happens to you. Um,
Same for patients, they get to decide. The big rule here is you cannot touch, treat, give medicine, or do any procedure without their permission. That permission is called informed consent. And here is the most important part, they have the right to say no. Even if you think this medicine will save their life, even if the doctor says this is the best treatment, if the patient says, I don't want it, you must respect it. And that is their right. For example, a patient has a tumor. The doctor says we need to operate to remove it. The patient says, no, I don't want the surgery. I want to try the natural remedies first. You might think, as a healthcare practitioner, that's risky, but you cannot force them. You explain the risk, you give information, but you respect their choice. Okay? However, sometimes, again, there are clashes, no, with autonomy, and we will be discussing that in the succeeding slides. This real case scenario, we have discussed this a while ago, no, on ethical conflicts. And this is again one example, no, when autonomy is clashing, no, with another ethical principle. Okay? And in this case, again, the ethical conflict is between autonomy and non-maleficence. So this is actually a model of case analysis that comes also from Viach and Gilderoy Grimes, no, book, and it is also based on the four-point moral evaluation created by moral theologians and ethicists over the century. Okay, so I will not be discussing anymore this ethical scenario since I have discussed this a while ago. Here is again another case. No, actually we have discussed this also already. No, the truth-telling dilemma. So I'm just showing it again to highlight the conflict, no, between autonomy and another ethical principle, which is veracity. No? The ethical principle of veracity. Okay. And since we're discussing autonomy, let's also discuss the patient's Bill of Rights, no, especially here in the Philippines. Um, Patients, no, here in the Philippines, patients have 12 official legal rights. You will see these posted in every hospital, and you must know them. So let me highlight only the most important ones, no, that you will use every day. First, of course, is respect. Always be polite, kind, and treat the patients with dignity no matter who they are, because it is their right to be respected. Another is the right for complete information. You must tell them everything about their sickness. No, they have the right to know about their sickness. They have the right to know what medicine you give, what might happen. There should be no hiding facts. Okay. Another one is the component of the informed consent. Signing a paper, no, for the informed consent is not enough. The patients have to understand and agree freely to whatever procedure or intervention that they are going to receive. Next important component in the patient's bill of rights is the patient's refusal. They have the right to refuse, no? Yes, even in our culture where family often decides, the patient still has the legal right to say no. Okay? And another is the issue on privacy. We need to close doors, speak softly, and definitely don't share their information, not to anyone else. Okay? Except, of course, if it's needed, no, within the team, within the healthcare team. And another important part, no, in the patient's bill of rights is the access to the patient's records. Patients have the right not to ask to see their own medical chart anytime. Also, they have the right to know who you are, so you have to introduce yourself. They also have the right to have their spiritual needs respected and to complain if something is wrong. No, they have that right not to complain if they feel that something is wrong. So take note, no, that even if the family says don't tell the patient, remember the law says the patient has the right to know, and we just have to do it gently and with kindness. So I hope that you can read through these the specific contents, no, of the patient's bill of rights, so that you will be more familiar. Now, to make it easy to remember all the patient's rights, we use this acronym, patients. No? Every letter stands for one right, and it spells exactly who they are. Let's go through each one simply. P is for privacy. So each patient have the right to be private. So when they are with us, we close the curtain. When you examine them, you also don't talk about their case in the hallway or in the elevator. A is for autonomy, and we just discussed this a while ago. So the patient gets to decide. T is for treatment info. Oh, so the patient has the right to know, must know what is wrong with them, what we are doing, and what it costs. No secrets. I is for informed. So the patient must understand what you said. We don't use big medical words, no, that they don't understand. So we explain simply. And E is for education. We teach the patient. We teach them how to take their medicine, how to eat healthy, how to recover, how to maintain their health. N is for no restraint. No, we cannot tie down the patient or lock them up just because they are confused or noisy. Restraint is only used no in extreme danger. T is for trust. So everything we tell, no, or everything the patient tells us stays with us. So their records must be kept, no, confidential. And lastly is S, which stands for services. No, the patient get good care. No matter if they are rich, poor, old, young, or what religion they have. No, and these are not just nice things to do. These are rights, no, protected by law. Okay. So again, to remember easily the patient's rights, you can use this acronym. Now there are also laws, no, in our constitution, um, that is about autonomy. No? If you break these, it's not just unethical; it's illegal. So you have to memorize these laws. Okay? And let me just mention a few. Yung Republic Act, first is the Republic Act 9439, or the Anti-Hospital Detention Law. And this means you cannot hold a patient hostage just because they haven't paid their bill yet. Okay? You cannot keep their ID, their clothes, or lock the door, no, so they can leave. Because we have mentioned informed consent, no, in the previous discussions. And this is actually one of the most important things that you will do, getting the informed consent, no, signed, no, from the patient. So let me break this down clearly because many students think that uh, informed consent is just signing a paper. No. Let's discuss also two related ideas, which is paternalism and proxy consent. Paternalism is like acting like a parent. I know what is good for you, so I will decide for you. And there are two types of paternalism. One is the strong paternalism, and the other one is the weak paternalism. In strong paternalism, you decide for a fully alert, capable adult, which is actually wrong because this is taking away, no, of the autonomy of that person. So we never do this. For example, you think this medicine is good for them, so you will just give it without asking. So that is wrong. No, that is unacceptable. And the other type is weak paternalism.